Study Club 4. I'm going to be running through Edgar's treatment this evening. I hope you're doing really well. It's a beautiful evening in Lancaster here. Nice autumn evening with the sun just setting. So I'm going to run through this case. It was a really interesting case. I enjoyed treating him. And but the outcome right at the end wasn't quite as satisfactory for Edgar as I'd have hoped in terms of his overall feelings about this. So what I'm going to be doing is just showing Edgar here and taking him through the treatment journey from having this plastic acrylic-based denture, which you can see is not fitting particularly well, to this really nice Scandinavian denture. And I want to go through the ups and downs of the treatment with you too. Now, just to make this super interactive, because this is a webinar and I can't see any of you here. It's just I'm just looking at the screen here. Please be interactive. Put some stuff in any questions in the chat or in the Q&A section, and I'll just delve into that as we move forward. So I treated Edgar maybe a couple of years ago, um, and ever since COVID, I've been doing my first contacts with patients via Zoom or telephone calls, and I found this really useful for just finding out whether I'm right for the patient and the patient's right for me, whether we're just on the same page, really. And it has been really helpful. And you can see Edgar here showing me his acrylic-based partial denture just there on the screen. Gives me an idea of what's going on. What I really want to know from him is, and Edgar was referred to me by a dentist, is relatively local to the practice in Lancashire in the northwest of England. He lives about 20 miles away from the practice, so quite a close patient. So I want to know what his problems are. This is really so important, and listen to them. And this is my first mistake really with Edgar, was not to really listen to it. And I've gone back and listened to my discussion with him on this first point of contact. And he was really focused quite heavily on the tipping when biting of the denture. Um, I didn't really give it too much thought because I thought, gosh, I can make this denture much better than that, a new one. But anyway, that's what he was talking about. Also, he felt that this section here was a little bit too far back and it was making him gag and have this sort of gagging, heaving reflex. Plus, he was not happy about the look of it. So, and you can see here where this is his smile there with that acrylic partial denture, a little bit of a tatty post crown just there like that. So this was his wish list. I want to, he wanted his smile improving, and he wanted to improve the chewing of his food. So these are the things here. So I said to him, look, it's going to cost somewhere between £7,000 and £15,000. That's the range of costs, depending on what we need to do for you. So he chose to come in and have a consultation. So this is him at the consultation. Take lots of photos and I can have a good look at this. So you might hear my dog barking in the background, Fred, because I think Rachel might be coming home quite soon. So if you just ignore him in the background, I'm sorry about that. So look at that though. This looks so bad, doesn't it? That the way that denture sits up against the crown there. And I'm thinking, gosh, we can improve on this. Definitely. So that's it there with this acrylic-based denture, that tatty post crown. And also shortened dental arch in the lower. We've got the first premolar on this right-hand side going round to the second premolar there. So SDA, a little bit of tooth wear. Edgar's in his 80s. He's quite an old chap, but well turned out. Oh, he came in a suit and a tie and was very upright and sort of proper about these sorts of things. So and in particular, that's the word, almost military style, particular. So look at that. I just thought, gosh, this is an easy win to make this better. look at this plastic thing here, and I'm thinking, let's just get something with a path of insertion like that, and we can close all of these gaps and make it look super good there. So that's it looking from above, and it looks like the dentist who's fitted it has really had to grind it away to try and make it fit, and made these gaps there. And there's a secret to avoiding that, by adjusting it underneath this collet edge there, which I talk about quite a bit on a lot of my videos there. So he's got this SDA at the bottom there. These are his radiographs. Heavily restored dentition, caries prone. Just focus on this right-hand side here. That's that post crown. It's one of these dentata screws screwed into the root surface. Immediately when I saw that and how it didn't look very nice in the mouth, I thought, let's just trim it down and do an overdenture abutment. Just leave it as an overdenture. This is an old, um, tooth there with it's had recurrent caries, a little bit of a patch up. There's a crown in it. Still very useful. Terminal abutment on the upper left-hand side. I don't like doing lots of stuff on these teeth though. This is the mouth there. Looking at it without this is the without the denture in place. You can see he's got good oral hygiene. There's no pocketing on these sorts of things. There's a little root there. That's fine. I tend to keep those. Um, so, and we've got that post crown just there. So this is his presentation there. So this is once I've done my photos, I've seen the patient in the chair, I then do a quick design, a quick partial denture design just from the photographs of the mouth. I've examined the patient there. So this is my Scandinavian denture, which is keeping it clear of the gingival margins. I'm using maximum tooth support and also maximizing the support from the palate too. This is a great area, but also keeping it short of this area here, the back there, because I want him to be able to swallow comfortably, because his previous one was extended further back too. So I was also thinking, let's get this post crown down to gingival level. It's underneath that denture design there. So let's just trim that right down, just like we've got an overdenture abutment here. He had a previous bridge, a cantilever bridge that had failed at the front there. Now, Edgar, this is one thing I've forgotten to mention, which is super important, is that he had explored the implant route and he really didn't want it in terms of surgery. And that's how he ended up being referred to me through the dentist, because the referring dentists do filter out these patients who may want to have dental implant there. So they'll go to see another practitioner for that, maybe another specialist. So this is it. And so, yeah, this is the whole design there. Single back molar. What I love on these single back molars is a ring rest just there. Just remember, please, fire in any questions into the chat box there. So it's a ring rest on that back tooth, a nice clasp coming off there. It's gold or wrought chrome, depending on where the survey line is. Quite like a gold clasp coming off here. So if I've got an undercut in that area, the gold can come off and fit into that. But if there's no undercut there, we could also bring a chrome clasp round that edge, round there like that. That's a ring rest. Maximum support. This is a resin bonded bridge just here. I'm happy just to overlay the denture onto that. So we'll have metal backings on the back of these, and then backings on that, and a nice, good, positive distal rest. I'm happy to prep that tooth as well there to put a nice rest seat in. This is a metal ceramic crown too. So he chose to go ahead. And so we'll fast forward to treatment visit 1. And so I want to get a really nice primary impression, upper primary impression. And I love using this injectable alginoplast, which goes into a large syringe. Alginoplast is made by Heraeus Culture. It's really easy to get hold of. And then I put a nice thick mix of alginate into here, and then squirt that gets squirted into the sulcus. all the way up into the sulcus like that. And then the dense ply blueprint is the base material in the tray. And I wanted to capture the full sulcus depth of this. So that's my primary impression made using blueprint and alginoplast. And I do an impression of the lower arch too. I've got this made in alginoplast. I'm not making a lower partial denture for him, for Edgar. I don't do that. Even in the short and dental arch situations, he's got 9 lower teeth. He can function really well with those 9 lower front teeth too. So looks like Jeffries as her hand viewed. So I'm just going to, she popped her hand up. I'm just seeing if there is a question there. And I want to just see if I can see if there's questions in the chat box there. So it looks like you've got a hand up there, Jess. If you could just pop your question into the Q&A section or just into the webinar chats box, I can see that just now. And it'll just pop up on my screen just here. So let's move that out of the way. Lovely. So yeah, no need for a lower partial denture for him. You know, if he had more missing teeth, then I'd definitely consider that in terms of improving chewing function, but also balancing the upper denture there too. So once I've got the primary cast, I then revisit along with Rowan. We look um, at the primary cast there, and we work out whether this first design that I've done is actually possible. And you know what? Most of the time, 80% of the time, it is really worth doing. It's I'm actually I can actually go for it from that first design. And sometimes it just needs a few little tweaks just from looking at the teeth. Jeff's has put in, was the sinus really, really low on the periapical radiograph? Let's just have a little look at his rads. Yeah, absolutely. He's also definitely. So there's also a root in there too. He's a retained root person. There's a retained root just here as well. So bits and pieces going on there. So, and you know, from my perspective, he's in his mid 80s. If it was um, my dad, who then with this sort of mouth, then that's what I'd be suggesting to do rather than going for implants. Certainly in the first instance, I think that's the right thing to do. So, thanks, Jess, for that question. So, let's go. Let's have a look at the design there. So, that whole design did make sense really nicely. Now, really importantly here, just as a standard approach, the Scandinavian approach that I like doing, it's 2 clasps per denture. That's my normal approach, and that works in most of the time. So we've got 1 clasp here, that's the X there, gold clasp coming round onto that tooth there, and also that gold clasp coming back onto the upper left 7 works nicely too there. I've also looked at this. We look at doing preparation on these teeth here, just to make a little rest seat, skim a little bit off that Pontic, that resin bonded bridge, a rest seat, and a nice good rest seat there too. So that just gives me an idea on what I need to do there. The green dots on my design, Jess, it's just making me sure that I've got good guiding surfaces, so that I've got nice parallel surfaces to just make that fit. It should really have guide surface, Jess, across there, across there, across there, 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 and there. So on all of the natural teeth, just so that everything just fits in nice and parallel. So just do little adjustments on that there too. Right. So, and then the other thing I'm really sort of thinking about here is I like when I've got my primary cast is I want to think about getting this post dam or this e- posterior border further forward, just because he's got this gag issue there. So now I'd still want my special tray to extend beyond that. So we've got really good scope for finishing the denture exactly where I want it to go. So, but this is the custom tray that I've made. It's got little holes in over the teeth so that when I do my impression, then it's going to lock into that with the adhesive there. I want it nice and short all the way round. So I've got scope for doing border molding, and I want it just to fit into the mouth there, just like that. So that's my custom tray, light cured. There, nice and rounded, good riveted holes there. So let's fast forward 2 weeks to my working impression stage. So I've got the patient in now. So I've got Edgar in. And so this post here, this post crown, what I did is, well, I just trimmed that down, right down to gum level. Um, Many of you probably know I'm not very keen on attachments or studs or things that go into teeth, just purely because they add complexity and they often break. Patients get cross when these things break. It's expensive to repair, etc. So I just like to keep things really super simple. And Rowan loves it, and all technicians love it if I really give them loads of space. So I've trimmed that post crown right down. That's it there to that level. And then this other root surface, this upper left one, I get that right, trim it right down. This is a bird that I love using. It's like a rugby ball or an American football shaped burr. I can just sand the tooth down like that. I like to just adjust crowns as well too. So just making the guiding surface right, do a nice rest seat. I use a little got a round burr about 3 millimeters to do that rest seat there. And when it comes to doing the little rest seats there like that, like using a crown prep burr too. So I've got a nice question from Peter, and here. So Peter's, hi, I'm a CDT. I routinely use a lot of your tips and methods for fabricating my dentures, both technically, clinically, and technically. What advice would you give regarding being able to charge higher patient fees? Um, I think it's the fee structure this is a very sort of personal thing, Peter, in terms of um, but I just believe that certainly in Britain here, the NHS fees for like partial dentures and any sort of dentistry is just incredibly low. And the craftsmanship that goes into making these lovely metal-based partial dentures is massive. It's like a piece of jewelry. And it's so artisan, it's so beautiful. I think it's really valuing that input that goes into it. And if and that's how I try to think of it, if it being a bespoke item that's really crafted specifically for that patient. And therefore it is going to cost a lot of money. So it's a little bit like the L'Oreal adverts. It's, you just got to value, you're worth it. You are worth it, Peter, as an expert providing this for your patients. Um, and it allows you to have more time to spend and get things fitting better. So it's I could talk for ages about that, but it's really about valuing what you do, because it really is an amazing piece of kit, this. Um, and patients do appreciate it too. I'll come back to it later. So this is me after prepping. You can see I've done a lovely rest seat in that. I'm not scared about these when it's a metal ceramic crown, just there like that, to just go right into the porcelain, right through into the metal thimble, the coping underneath. And it's deeper there than at that bit there, so that it helps to hold into the tooth. You can also, if you see, there's a nice little groove there, across there for that just to sit in. These sorts of rest seats are really lovely. That's the post crown. I've just cut it right through and just left that screw inside the tooth, filling it. So I've got a question. Thanks. Hi, Samuel. When when went to decide to extract remaining root or just reduce to bone level? Risk of infection. Absolutely, Samuel. I do love roots because they do offer proprioception. Um, and I like to do minimal intervention for these patients. But you're absolutely right. I have been caught out in the past where a root's got infected underneath the denture and it's, it's swollen and bloody blah. And then the patient's got really cross about it. He was actually my mum's um, financial advice. He was an older chap in his 80s and that happened to him. And he was so cross, but I'd kept it for the right reason, just because he's a bruxist and heavy on his teeth, just like in this case, Edgar's heavy on his teeth, and it offers support. However, this is really important. It's horses for courses. If there is infection around something, I would take it out beforehand. So, will you leave the retained roots up left 4? Can this cause an issue for the denture pressing on it and causing pain? No, I'm not at all concerned about those roots there at all, Jess. But if in doubt, it's dead easy just to numb it up and flick it out. No problem. Great questions, by the way. So I do that. And as you probably know, just at the moment, Rowan is off ill and he's not been back. He's not been in for just over 3 months. So I'm using Sam just down in Bolton, who's just away from me. But at this, I saw Edgar when Rowan was fine. So I do a pickup impression. This is how I do it for Sam too. Just do a pickup impression there of the denture, and then that just goes through to the lab, and then a tooth can be added on where I've cut it off the denture so that Edgar is socially okay by the time he leaves the practice later on that evening. Now, with Sam being away at the practice there, what I'd be doing is I'd be doing this on a Monday, this imp, and then I'd get it back on the Wednesday and fit it. So it just needs to be a day without it at the moment. I want to do my working impression here. So once I've done my preps, I then did my working impression. So I've put my compound onto the areas of the custom tray. And do you know what this does? This is really important. It just actually, that green stick stops the tray from touching the teeth there. So it actually just jacks it away. And it means I can take lovely impressions of these teeth without them scraping on the tray. I also do a little bit of border molding because he's got a freehand saddle just there. So, and then I pop some adhesive all over the tray, right onto the different surfaces too. And then I mix up my blueprint, and I do this quite a runny mix. It's not super runny, but it's more like a medium consistency. Rub that into the, and also I've got some on my finger, rub it into the occlusal surfaces of the teeth, pop that in the mouth, and do that. So that's the working impression in his mouth over those teeth. And then I'd also do my border molding for that. He's got a free end saddle on the upper right hand side there. So this is the impression there. You can see lovely, clear, and all the detail is in these on these teeth there, with no air bubbles at all. It's just lovely and smooth because I've glazed it. I've also border molded just around that section there too, which is really nice. So that's the working impression. Now, this would go straight through to Rowan. This went straight through to Rowan in the room next door. That's where Rowan, my technician, works. And he'd pour that up straight away. Now, what I'm doing now is I'm posting these so they go through to Bolton by post. And that's around, so it's probably 1 or 2 days before it's cast. And I found that the chromes fit perfectly well. With doing that too, which is great. So that's the impression there. I've got everything on it I need. So now, by the end of the day, Rowan had this extra tooth added onto the denture. You can see there. That's where that old post crown used to be. So, and then fit that back in. It's quite nice. These often fit better, once I've done stuff like that for them. Also, at this second visit, I do a bite record. I did a bite record too. This is in maximum intercuspal position. So his natural full meshing of his teeth is good bite position. I love this stuff, which is called Futard D bite registration material. It's beautiful stuff. And I got him to just close right through that there. And then that goes off with those working impressions too. So Edgar goes. He's got this extra tooth fitted. He's ready to go and he's fit to leave. So those models get poured, and here we've got the working cast. So the upper working cast has been poured there, and it's also been mounted using that intercuspal bite record that I had at Futard D. And so we've got wax blocks on there. And the really important one is this. This is this is the working cast. And then I've also got a mock-up in pattern resin here. This is Duralay. Interestingly, this is being done more and more with printed patterns. People are doing these in printed, which is really nice. It's a lovely mock-up which you can do for the mouth, and it's got the wax blocks on. And this is prepared at that vertical, um, at the maximum intercuspal position, at a slightly increased vertical, because this is going to be a splint, this thing. So the dual registration stage. So this is visit 3. So let's just pop this in, and you can see that that's the wax rim in there. And I put on exactly where I want the midline to be and trim it, if need be, to where I want the replacement teeth to go. The great thing is I just tried it in and got them to close together, and it was just, and said, which side are you touching first, Edgar? And he says, I can't tell, it feels even, which is great. Now, if it wasn't even, I would actually do the bite record with that lower rim that I got made at the same time here. So I've got a lower rim made at the same time in case my intercuspal record or the way that we recorded it was not accurate, if I need to do it again. But it was great. It was fine in the mouth, you can see there. This is so important. Just giving the technician this information is really good. So this is just prescribing where I want the teeth positions to go. So that's it, nicely carved in the mouth. Here we've got the, with the lips together and then a good smile. And I like taking all of these different angles of photo, and then the technician can have it. And we can also, obviously, I don't want you to see him as a person that's anonymized, but we look at it with his eyes on the screen too, and we can really see whether that plane looks good in his face, in the whole face there. So after that, teeth are applied and placed onto that try-in. And you can see here that really importantly, I'm going to show you this just in a minute. If these teeth at the front there are gum fit like this there. So I don't like having pink on when I've got roots underneath. We've got a root underneath that tooth and a root underneath that tooth. So it would look weird having these sort of pink sections of flanges. They don't really work very well. So I sort of think of overdenture abutments as being a little bit like a removable crown. That's the um, and this is a single tooth at the side there. Again, no pink on it. It looks better without pink. I think it's really, really important there. So let's get this prototype tried in. So now, Edgar, this is sometimes in terms of shades, and I didn't in the newsletter, I didn't write this in, I forgot to, but he um wanted the teeth that colour. I just want to take them down. Every time I look at this, I think, oh, flipping heck, I wish they were just, I think these might have been A1 or A2, and we should have got it back to an A3 like that. But anyway, but if you ignore the colour, just see what I mean by the way these fit onto the gunwork really nicely. And if we had pink on it, it'd just look really weird. Um, if Edgar had asked for a lower denture as well, would you go ahead without question or speak with him about not having one? Jess has asked about whether um, I would definitely, if he wanted a lower, um, I don't know actually. There's a high chance because he's still got so many lower teeth there that he wouldn't wear it. It'd be one of those, even if it was a really look beautifully made denture that fits perfectly and is as comfortable as anything, a lower bilateral free-end saddle partial denture is not well tolerated particularly. So it'd probably sit in the drawer in the bathroom. But so if he lost like if that premolar was missing there and it was just round the canine, then yes, I'd be thinking about doing that just to help to balance up the bite properly. So that's the trying and look at how lovely that single tooth looks there with no gum. What's the advantage of a toothy grin? Has just asked what is the advantage of the Duralay trying? It's brilliant. I love it because I don't know whether I've got an occlusal view of it. Yeah, the Duralay pattern trying means that the patient can just assess it, and it gives them quite a good feel for how the chrome's going to feel in terms of size. Number one. Number two, which is dead important. This is super important. I can just test the accuracy of my model. So if it fits nicely on the teeth there, it gives me a good feeling that the metal base is going to work too. Thirdly, they stay in better, toothy grin. They stay in better. And also, the patient can have a good look in the mirror and I can say, okay, could you open really wide? Right, that's where the metal will be. And that where you can see it bright red, that's where it's going to be in metal. So there's lots of advantages. I love it, actually. Doing it. So once we've got the Duralay trying and it's working and we know that the teeth are in the right place, that's when the next visit we'll make the metal base and do that. So we go from this to that. So the metalwork gets made just precisely according to the design. Now, can you see here that we've got metal on this section there? We're going to have a false tooth just there. We'd have a false tooth in that area there. But this metal here is going to protect that false tooth because if it didn't have that backing, then the artificial tooth would have a tendency to snap off, particularly in bruxis like him, particularly in shortened dental arch, and he's heavy on his teeth. So that's really quite important too. So this is and so the metalwork is made on the mounted casts so that the occlusion can be just right. It's just like making a bridge, isn't it? It's no different than making a fixed bridge because I want the occlusion spot on. So we've opened this up. So he's going to just bite onto this new denture. So it's going to be like a splint as well. So this is looking at the chrome framework. This is the back tooth. We've got that lovely gold clasp here, wrought gold clasp. So we can tighten that really easily. Nice ring rest and these lovely backings that just sit onto these teeth. That's the This is that where that artificial tooth there, the four that's going to be behind the canine there, that's got this metal backing and that's been painted tooth colored um, in there too. Jess, when you say to the patient that you want to prep teeth for restes, do they ever refuse this because they don't want their teeth drilled? Yes, they do, sometimes. And do you ever not prep teeth for rest seats and then the patient bites onto the rest seats and feels they can't close properly? So the first question is, yes, I have had one person refuse, and so I chose not to proceed with treatment for him, and I just refunded what he'd paid so far. Um, I say to the patient that prepping the teeth is really important to make the denture function properly. And if I'm not able to prepare these rest seats, then the denture will accelerate the failure of your teeth. It will accelerate the demise of your teeth quicker than if I don't. So if you allow me to prep your teeth, it will protect your teeth, and I'll be able to the forces that the denture is going to apply onto your natural teeth will be more evenly distributed, and it's healthier as such. So therefore, it's a really good idea to do that. Now, sometimes, Jess, with do I ever not prep for teeth? Yes, sometimes I do no preparation at all, particularly where it's these big overlay dentures where there's a whole new occlusion um, happening on here. But to a certain extent, this is what I do for I'm doing for Edgar here. So I have actually prepped um, a lot of these teeth, just little bits. So even in cases where I'm doing lots of overlays, I'm still doing quite a little bit of preparation, putting the primary cast onto the surveyor and looking where the guided surfaces are going to go, where it's going to fit into these teeth and hold up better and look better. So, so no, I routinely do prep these patients. And this is where Peter, as a CDT, Pete Livesey, it's great to hear from you. This is where it's really important to have a really cooperative dentist that you work with, a clinician that that will be your robot. I am Rowan's robot, so he tells me where to prep the teeth to make the denture fit better. Pete and CDTs, you need dentists that will do this for you because it really, it makes this is the detail that makes them fit so much better. It's great. So, this is looking at the other side. We've got that lovely gold clasp coming onto that premolar there. So, and you can see how, we're keeping it away from the gingival margins as much as possible. Everything is away so that the saliva can get to these areas and just protect these teeth. Beautiful. And that's the fitting surface of the chrome framework. So these areas that touch the teeth, if I need to adjust them, I re-sandblast them so they fit really intimately and they've almost got a little bit of retention on too. So let's fast forward now to treatment visit 5, metal-based try-in. So I just want to try this in bare without any teeth on, just to ensure it's fitting nicely. And if it most of the time they fit like this really snugly, but sometimes I do need to do a little bit of adjustment, and it's often around, say, a tooth like that where it's got metal on both sides. And in order to do that, I use this occlude spray. If you look at some of my other webinars, online resources, you'll see how I adjust this really nicely. Nadia, Nadia, hi. If the Duralay framework doesn't fit, do you retake master imps or can you adjust? So yeah, if the Duralay is just slightly off and it just needs a little adjustment to make it fit, then I'll go ahead and make the chrome. But I need to remember where I've adjusted the Duralay because the metalwork will hold off in that same place. If it's just not going near, then it is a new impression. But seriously, Nadia, in the past, it's so rare I have to do a new impression. I've only seriously had to do, in off the top of my head, one impression for a remake since I've been working with Chris Hesketh, so it's really rare. So it's the impression that's key. That's the most important stage actually, is taking the impression. Nadia, great question. Thank you. Um, Also what I'm checking here at the metal-based triangle, look at that even occlusion. It's lovely, even on that metalwork, both sides, simultaneous. If he's jacked on one side or the other, then I will mill that in a little bit, so, but I'm, if it's slightly off, I'm reluctant to do it. I prefer to just go ahead and finish it and then mill in the occlusion. Once I'm totally happy, everything's sitting down nicely. But, that was just really nice. The bite was great. So that's the whole framework just tried in nicely. Just a little tip, super, super important. Anyone that's not listened to me before, when I'm adjusting my metalwork, if it's not quite seating, what I avoid doing is adjusting the edges here. This is the edge where this backing, this metal bit fits up against the tooth. I'll adjust anywhere underneath that using my occlude. Same across that ring rest at the back there, underneath there. Super important. So once we're happy that this metal base is fitting, now I go ahead and we'll finish the denture. And this is the mounted working cast. You can see on the articulator pin there, it's set at -1 millimeters where it's closed right down. And the denture has been made at 0, it's slightly open. So it's 1 millimeter at the pin. So the metalwork from underneath here, I like the metalwork to be around about 0.5 of a millimeter thick. I don't want it any less than that. So it's about 0.5 millimeter thick. Hello, hiya, John. Uh, what do you do if this is John Besford, my mentor? So I'm actually feel a little bit under pressure now, and I can feel myself going warm. What do you do if one or more abutment teeth are mobile when I'm doing the impressions? So, John, what I do, and I know you know the answer to this, is I will support that tooth, the wobbly tooth, with composite. So I'll make a little splint from a solid tooth and do like a little sausage splint of composite, bond it onto the wobbly tooth in its passive position. I'll make sure I put the composite on the tooth that on both of the teeth outside of where I want all the components of the metalwork to go. So it's not going to get in the way of making the chrome. And so I'll do the impression with that splint on, my working impression, and then I'll take it off and I'll take the impression out and then sand off the splint there. So we've got our working cast. You can see here also, I'd like you to note there's a little bit of a pin dam cut on here, just to allow the denture just to sink in on its peripheries to avoid ingress of food underneath that too. So, and you can see the setup there. Look how Rowan's got this nice setup just here with that lateral incisor. A nice natural setup there too. And this is the finished product with no gum. We don't like superfluous pieces of gum on this single tooth there, on these anterior teeth that's sitting over the ridge. There, this is looking up from the back. And then this is from the side here. So lack of gum there, just feeding into that area. It just looks better in the final product too. So there we've got the fitting surface ready to fit. And you can see how we've kept it away from these gingival margins too. Really important. So it's nice and cleansable. So nicely extended around this hamular notch on that denture to there. That's great. So can you see how these artificial teeth just fit nicely into the gingivae there, erupting out the gingivae? Right, let's get this in. So this is treatment visit 6. This is the fitting appointment. And here we've got Edgar with his bright teeth shining at me, um, fitted. So I was, I did, I was very happy with that fit, and the occlusion was nice too. We've got this gold clasp just on that premolar just there. Lovely guide surfaces. Look at that. So there's no gaps between the teeth, but we've also got this natural gum here. It just looks so much better than this, these artificial pink triangular bits of gum tissue too. So now when I fitted this, sadly, the unfortunately the denture here was just a little bit loose. It just didn't stay up particularly well on that side. I'll come to why that is the case here, and it's because of lack of flange, but I'll explain, I'll talk through that in a minute. So just dropping down there. So what I decided to do is just tweak that clasp a little bit there. This gold clasp, just tighten that up. Um, and so that I fitted that for Edgar, and off he went. So that's it with it fitting. He liked the look of it. He was pretty pleased actually. Went out the door. And then he went across the road to a cafe to Booths, and I got a phone call from him. Just one thing here, I've got a question from Hein. Hi, Hein, you're from New Zealand. Great to hear from you. Hi, Finn. Please give me an idea of the depth of model ditching for the gum fit anterior teeth. Um, so on the working cast, I don't do any uh, ditching of the model at all. Um, it's a really good question. What Rowan does, we just overlay it on the cast there. So this is effectively just lipped over. It's almost like a little flange, really, Hein, on all of these teeth there. So it just sits over. So there's no cutting back or uh, you know making a pontic area on them. So let's just go back to Edgar. So off he went. He left the practice, and then 20 minutes later, I got a phone call. We got a phone call. It's really sore. I've just been over at the cafe across the road, and it's hurting. So I said, right, come straight back in. Let's have a look at you. And um, what I what I hadn't checked when I'd come to fit the denture and I'd forgotten to was to check the extension of this saddle area here. And can you see, this is from my head cam. It was actually bleeding just in that section there. So in order to check this, this is what I did. Um, I squirted this silicone impression material on here as a fit check. This is Doric Flow. Popped it on into the mouth. So that goes into the mouth. I get him to drink some water, just have a sip of water like this. A good, powerful swallow, and then let it set. Take it out, and then I mark up where the acrylic's poking through with a Sharpie. This is the back edge of that there. And then I grind that off there and just repeat it until it's not rubbing off. And you can actually see here what I did. I went from this is the how it was finished, the denture, to that. So these areas I think are really critical. These little, the raphe, the pterygomandibular raphe can just catch and get in the way. So I think doing a swallow test is really crucial, both upper and lower, when it comes to fit. So let's fast forward 1 week later. And this is Edgar. He took it. He said, "Look, it feels sharp." He's been running his tongue under it on that edge there, and he pointed out this area here where it just felt a little bit rough. And so this is the situation of the tooth there. So that's the upper premolar there, and the metalwork, the overhang of the metalwork was just a little bit like that. And it would have been preferable if I'd have just prepped the tooth more to allow a more of a flush finish to the base of that area, because often patients can get the tongue underneath these sorts of things. So what I did with this was that overhang, I just sanded that down just there, just trimmed that away there. He also said, he felt it was loose on that area too. Tightening the clasp. And then I tightened the clasp and off he went for another week. And he came back with toothache on that molar there. It was really quite sore. I've been almost orthodontically pressing on it on there. It was aching. So I backed that off. And the issue, this is this is a really important point, a learning point here is that if I'm doing, this is Edgar's denture there with without the flange on the front there. When there's no flange at the front here, we can't utilize this lovely guide surface just there to hold the denture in. Can you see here? This is one where it's got a beautiful flange at the front there. I can utilize that guide surface underneath there because there's all that missing tissue. There's missing bone, missing roots. We can utilize that to help hold it in. But in these circumstances, I can't. So what we decided to do is to add a clasp on to that tooth here. Let's have a look, shall we? So what Rowan did was he added a clasp on. So we've got 3 clasps on this denture. So most of the time, 2 clasps are perfectly adequate, but sometimes I do need 3. So we popped this lovely creeping clasp on there, just added it into the flange. And that once we tried that, it really worked beautifully. But I can just show you can see here before the clasp has been added. This is after the clasp has been added. So it's just embedded into that acrylic work there nicely. So that worked well. I like to weigh the dentures. This is 15 grams. This is pretty standard for a metal-based denture like that. You quite often lowers are a little bit less, maybe about 10 grams, but not heavy at all. But this was the partial denture fitted with that creeping clasp just on there. And that really helped to sort that retention out nicely. So, because I've not able to have, well, I could have had a flange on there, but it just would have looked really too bulky because we've got this really perfect tooth position with nice root support underneath it too. So that's the old to the new there. You can see there's no pink on the on that denture there, like that. Nice guide surfaces. We've got everything just tucked away. That's that old post crown we've taken off. New tooth there as well. And then with our creeping clasp, it's great there. So right, and then off he went. So then treatment visit 10, I wanted to review him after that clasp had been added, and he came in and he said, Finlay, when I push up on this side here, the denture comes down. It rocks with my thumb. And he was pushing onto the artificial tooth there. And I can do this with the denture. I can rock it up and down. And also, I noticed him sitting in the chair and doing this. He was going across to the side there. So this premolar was hitting the artificial tooth here and then causing the denture to want to tip down. Even with its clasp on that side, he was going into excursions with it. So this is me and Rowan. looking at the denture there. He's talking about it and saying exactly what the problem is. So we had a look at the occlusion. We checked that. So I wanted to check the guidance. This is the with articulated in paper in, and he's going over to the right hand side onto that artificial tooth. And then I adjusted the tooth as much as I could and did it to a point where I don't want to shorten it. I could take the tooth really way out so it'd look super bad. I didn't want to do that. So we just kept it as as short as possible, but it still was involved in the guidance. When it goes across, it's still touching there. So you can still reach that point. So I explained to Edgar, said to him, I can't stop this from happening. Um, when you are in your home bite position and your normal chewing bite position, it's not going to do that. But if you go into an excursive side position, because we can move our jaw into it can go into loads of different positions. There will be certain places in that excursive position where you'll make this denture tip. It's just the nature of a denture, even one that fits really well like this. And he just didn't buy it. He was not cool at all about that explanation. He said, it should not do this. And I had to just say to him, well, just, you can't, don't do it. Don't let it rot because it will just continue to do that. And avoid going into this excursive position. So sometimes with these patients, it's a little bit like having a mosquito bite that you just really want to scratch, but doing that just makes it worse. But it's just about working with the denture rather than against it. There are certain things it cannot do. It isn't a fixed prosthesis, so even a good fitting denture will do this. So so basically, this is why I called him the skeptic, because after, and this is the US spelling, which I think is better, skeptic with a K, it's just easier to pronounce and understand. It's a person that's inclined to question or doubt accepted opinions. And he was really skeptical about that. He felt there was a fault with what I produced. I'll come back to that just in a minute. But yesterday, interestingly, I fitted these for a chap called John, who is an architect. He's an architect about my age, very particular. I thought he's going to be tricky, this guy, potentially. And the whole fit went really well. And then I chatted through with John and said, look, John, you know, when your chewing function, when you bite together evenly and fully together in your home chewing position, that MIP, this is what I'm talking about, then everything will be stable. But if you go side to side and clatter this canine here, this free end saddle is going to want to tip. And he goes, oh yeah, I found it. And he said to me, I'm just going to have to learn not to do that. The way around this would be to have an implant just in that area, yes. But it's really about educating these patients. It's really interesting. So I've got some learning points here for me personally with this particular case, and it's very much I've obviously over promised and under delivered on what Edgar was expecting. So, and I haven't fully managed his expectations really clearly from that start. The denture's a great denture, it's technically lovely, but it's not fulfilled his expectations. So, and I must make sure that the patient fully understands those limitations without exaggerating or being overly enthusiastic about this. I'm a little bit of an enthusiast about these sorts of things, and I should really have pointed out these potential challenges there. And John, I know you're on the line now here, and this is what you always said, which I think is fantastic. And if I'd have said to Edgar right at the beginning, before I've even made this denture, right at the consultation say, look, we're going to make this, but it will still tip if you grind side to side. It's going to move. Then that's a diagnosis. If I'm having to explain that at the end, after he's discovered this, it's an excuse. Not good. But what I do find is you can't win them all with these patients. Some of them are just difficult. And I don't mean that in a bad way, too. They just are. So, thank you very much for joining me. I just wanted to just mention that if you want to explore this a little bit further, I'm running a course in November on partial dentures. This will be the last day that I just do a 1 day course on partials, because as of next year, I'm going to be running this course over 2 days, just because partial dentures are so technical, just like complete dentures, I just think delegates need more time. So that's on in November. We've just got 2 spaces available for that. I've got 2 for the implant supported overdenture course, 2 there available as well. But my partial denture, my masterclass next year is a 2 day course in May. So there's one in May and one in November too. You can just have a look on the website for that too. Also, next week, I am running my complete denture course at the practice on Thursday and Friday. So that's Thursday and Friday next week. I do have 2 spaces available there too, if you want as well. And if you're interested and got free time for the complete denture course, you can come in. And if you contact Lou at courses@shotlander.co.uk. So now, Amit has put, what's your red flags for knowing this patient will be what are my red flags for knowing that a patient will be a nightmare at the beginning? Often, Amit, I don't actually fully know that they are going to be a nightmare I until I don't know they're going to be a nightmare until I've started treatment, because quite often they're really nice at the start, and then it's maybe visit 2 or 3 that I start to the red flags are shown. All of my patients are red flag patients because they're all referred to me, and they've all been red flag patients to other dentists, and I'm here to help them manage these cases. So a lot of them are just the more tricky to manage. So I've got to really get in all of my diagnoses about potential issues right at the beginning, and I just didn't quite manage it with this chap, for some reason. And also, Amit, you've mentioned, do I have refund policies too? Do I have a no refund policy there? Um, so I've, over the past 17 years, I've given 2 patients their money back for complete. One's for a complete denture, which I mentioned last time on the last study club. It's a recent one. And sadly, this is a 10-year treatment process, and she's had some last dentures. I've refunded her. Now, I just, rather than going through a whole legal convoluted process, if the patient's not happy, I'm just happy just to give them the money back. So that's basically the advice I get from the um, defense organization, is money back. So that's her. She had complete dentures. It's actually an implant supported lower overdenture. It's 4 falls with implant supported lower. And then the other patient I refunded was a patient who'd been an alcoholic and been a drug addict too. So and I knew I can always see things I can improve on, and I thought I could help her, but I decided just to bail out. Graham Stokes actually was really helpful for giving me advice on that. He said, Finn, life's too short, just give her money back, and that's it. So, it's horses for courses. And I don't really have a policy because it doesn't really happen very often. But I just think that rather going into a long, sort of drawn out process, which is you have sleepless nights, bloody blah. It's better just to give them money back and move on. Can't win them all. Simple as that. That's great. So lovely. Thank you, Amit. Anyway, it's really great to see you. Now, I'm going to be doing light bulb moments on the 10th of October, and it's going to be next month. And just it's 7:30 in the morning, British summertime. So that means that if you're over in Australia or elsewhere, it's going to be in the evening for you, and maybe just easier to watch as well. So anyway, thanks so much for watching, and hopefully we'll join up again